Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
Hi, I'm Sue Telecat from the Bloomberg American Health Initiative, here to share more about the Bloomberg American Health Fellowship. If you and your organization are working to reduce overdoses, end violence, improve food systems, protect the environment, or support adolescents in the United States, you may be eligible for a full scholarship to earn an MPH or DRPH degree at the Johns Hopkins Bloomberg School of Public Health. From farmers to firefighters, to doctors to policymakers, the Bloomberg Fellowship can help you transform your career, support your organization, and make a significant impact on your community. Applications close on December 1st. Find out more at americanhealth.jhu.edu/fellowship.
This is Lindsay Smith Rogers. In this episode, an update on vaccines. Dr. Bill Moss returns to the podcast to talk about the big stories in vaccine-preventable diseases like measles and pertussis in the U.S. and what's happening globally with Mpox. We also discuss some exciting new vaccines in the pipeline. Let's listen. Bill Moss, welcome back to the podcast. It's so good to have you again. How are you?
Good. Thank you, Lindsay. I'm very excited to speak with you again.
Great. And today we are talking about all things vaccines, but we're going to start out first with a big topic right now, and that is what's going on in the U.S. with these outbreaks of vaccine-preventable diseases. What are the big stories here?
Yeah, so I think the first thing is just to remind ourselves that here in the United States, we've done remarkably well in preventing vaccine-preventable diseases and in achieving high immunization coverage. But we've not done as well as we can or as well as we should. And this is because there are pockets of communities throughout the United States where vaccine coverage is lower than what it needs to be. And so that requires concerted efforts, and there are various reasons for that. But for example, with the highly infectious measles virus, we are seeing an increasing number of measles cases here in the United States this year compared to what we've seen over the past couple of years. Now, I do have to say that during the pandemic, the measures put in place, whether it was restricting travel or masks, did have an impact on all respiratory pathogens that are transmitted through the respiratory route. And so this includes measles. So during the pandemic years, particularly in 2020, 2021, even into 2022, we saw historically low numbers of measles cases here in the United States. 2019, right before the COVID pandemic, there was a global resurgence of measles, and we saw more measles cases. It was 1,274 here in the United States than we had seen since all the way back in 1992. But this year so far, we're seeing more than we saw in the past 3 years or so. We have 262 cases here in the United States. We're not on track to beat that 2019 record, which is a good thing. But some interesting things about the measles cases. We're seeing it across all age groups. Measles in the United States is not just a disease of children. About a third of cases are in individuals 5 to 19 years of age. And interestingly, more than a quarter are in individuals older than 20 years of age. Not surprisingly, most cases of measles are in unvaccinated people or people with unknown vaccination status. But another striking thing, Lindsay, is that 40% of measles cases in the United States this year have been hospitalized. And some of that is for complications, some of that is for isolation, but that's a striking number to have 40% of measles cases hospitalized. And a lot of those are in adolescents and older adults.
I imagine that it's pretty difficult to keep someone in a hospital that has measles to keep them away from other patients too.
Yes, hospitals and healthcare settings in general need to be very careful about what we call nosocomial transmission, transmission within the health facility. And so that requires and a high index of suspicion, and really isolating individuals with measles from other patients. The real danger in a hospital setting is you've got a lot of people who are immunocompromised for various reasons, people receiving treatment for cancer. Those individuals you definitely do not want to get measles, because measles are going to be much more severe in those patients.
And I know that this audience is very aware that measles for children can be extremely serious. It is not something to be taken lightly. What about measles in these older ages that you're talking about?
Yeah, no, you're exactly right. I mean, historically, we see most measles deaths globally are in in young children. There are on the order of 100,000 to 200,000 measles deaths globally each year. But measles can also be a severe disease in older individuals. So we talk about this kind of J-shaped curve where you've got high morbidity and mortality in the very young and higher morbidity and mortality in older individuals. So it's very important that we not only protect young infants or young children from measles, but also older adults who are at higher risk of complications from measles.
And one other thing I want to pick up on is that you mentioned that people that are getting measles have a mixed vaccination status. What does that mean?
Yeah, so the vast majority of people who have measles in the United States are unvaccinated. There are some individuals who are, when the CDC tabulates this data, that they include unknown vaccination status. So it's just, there's no record or no, this would largely be in older adults where they just don't know whether they were vaccinated or not. We do see a small proportion of cases in the most recent CDC statistics. 8% of individuals in the United States who have confirmed measles had received one dose of a measles vaccine. 4% had received 2 doses, at least by history or record. So there are some what we call breakthrough cases, individuals who are vaccinated who can still get measles, but 88% of the cases in the United States were either unvaccinated or had an unknown vaccination status.
I was going to ask about that, too, because I remember a few years ago I had to get an MMR booster because it turns out I didn't have enough immunity. So is that, first of all, I know that the more people that are vaccinated, the less necessary it is for me to get a booster. But is that something people should be asking about?
Yeah, in general, the immunity from measles vaccine lasts a very long time. It is an ongoing question in a setting like in the United States where individuals are not getting exposed to wild-type measles virus, so they're not getting boosted by the virus, how long that protection really lasts. But in general, I would say it lasts for a lifetime. There's some waning. So in general, we don't recommend that the general public have their antibody, it's a measurement of anti-measles virus antibodies, have those checked and have that drive revaccination. In some situations, people do get tested or need to get tested. For example, people working in the hospital or healthcare facilities will sometimes have their measles antibodies checked just to be sure that everyone is protected in a healthcare setting. But in general, we assume that the protection from 2 doses of measles vaccines lasts a lifetime.
Great. So let's move on to another topic here. And this one kind of started to creep up last year. Let's talk about pertussis.
Yeah, so we are seeing an increase in pertussis cases here in the United States this year. And again, pertussis is also this is due to a bacteria, Bordetella pertussis, and a particular toxin that's produced by that bacteria. But this also is transmitted through the respiratory route. So again, during those the early years of the pandemic, when we were doing a lot to prevent the transmission of SARS-CoV-2, we also saw a reduction in pertussis cases in the United States. But this year, we're seeing a marked increase from what we've seen over the past 3 or 4 years, about 15,000 cases here in the United States. That's even higher than what we saw in 2019 and about 5 times higher than what we saw last year. So we tend to see here in the United States, these periodic increases in in pertussis cases. Again, it's a vaccine-preventable disease. One of the theories that we see, why we see kind of recurrences of pertussis here in the United States, and just so everyone knows, this is also known as whooping cough, is because we did switch in the late 1990s from what was called a whole cell pertussis vaccine to an acellular pertussis vaccine. And what that means is, and much of the world, in many countries, they are still using the whole cell pertussis vaccine. It induces a very strong immune response, but it's what we call very reactogenic, meaning that it can cause a lot of inflammation, some side effects related to that. So in the late 90s, 1997, the ACIP, the Advisory Committee on Immunization Practices, recommended that we move to a course using the acellular pertussis vaccine, but the immunity from that acellular pertussis vaccine doesn't last as long as what we saw with the whole cell pertussis vaccine. So here we do have definite waning of immunity and increasing susceptibility of individuals who were vaccinated previously. And so this is where, real booster doses can be helpful.
Do we know anything about the people that have been getting pertussis? Is it like the breakdown of unvaccinated versus maybe previously vaccinated?
Yes, the CDC doesn't report that those proportions specifically like we see for measles, but it is a mix of individuals. It's a mix of individuals who are, I would say, probably a small proportion who are unvaccinated. The coverage with the diphtheria, tetanus, pertussis vaccine here in the United States is very high among children, and it's often measured among kindergarten students. It's very high. So these would largely be, and I'm surmising this, individuals who were previously vaccinated. Maybe they didn't get the full 5-dose course in childhood. Maybe they just got some of the doses, but also because of this fact that the acellular pertussis vaccine, the immune protection wanes, this is going to be a much higher proportion of vaccinated individuals getting pertussis than what we saw with measles.
Do we think that there will be a change to recommendations around boosters for this?
There currently are recommendations for boosters, and there are different types of pertussis-containing vaccines. For example, in pregnant people, it's given along with a tetanus toxoid vaccine to protect from neonatal tetanus. There is consideration and ongoing work about whether we need to modify our current pertussis vaccine to keep it less reactogenic, like it is. We don't want to go back to the reactogenicity of the whole cell pertussis vaccine, but with a vaccine that would induce more durable immune protection.
All right, so let's move on and talk a little bit more global. What do we see in outbreaks of vaccine-preventable diseases worldwide?
Yeah, so we are seeing outbreaks of vaccine-preventable diseases globally, particularly, for example, with measles. We're seeing global increases in cases of measles, and that's what's really driving the increase in the United States. Yeah, so the Mpox story is also really fascinating and, again, tragic. We are now seeing outbreaks of 2 different clades. They're called clades or versions of Mpox virus. The big one that most people are probably familiar with was in 2022 when the World Health Organization declared what's called a public health emergency of international concern. That outbreak really spread, throughout the United States, throughout Europe. It really was a global pandemic, but it largely impacted men who have sex with men and those communities. Right now, this year, the World Health Organization, just in August, declared a second public health emergency of international concern because of an outbreak starting in the Eastern Democratic Republic of the Congo with a clade 1 virus. And this virus has been, circulating in the Democratic Republic of Congo for a long, long time. Clade 2 that went more global was originated from West Africa. So now we've got these kind of 2 different clades of the virus causing these outbreaks. They're very highly related virus. The vaccines that we have work against them. There are 2 vaccines that are approved by the FDA here in the United States. The Jynneos Mpox vaccine, very interesting vaccine. It's a called a live virus, but it doesn't really replicate in the body. And that's critically important because many people, particularly with that clade 2 outbreak, who are getting Mpox, that's a population where there's a higher prevalence of people living with HIV who may be immunocompromised. So you don't want to give a replicating vaccine to people who are immunocompromised. So that's why this Jynneos Mpox vaccine is so special. There is also a vaccine FDA approved called ACAM2000. That is not a replication incompetent vaccine. So that's a vaccine you don't want to give to an immunocompromised individual. And so what we're seeing now, Lindsay, is where there was this interest in this clade 2 global outbreak, a lot of concern around the clade 1 outbreak in eastern DRC that has spread to a number of neighboring countries. And there have been cases identified outside of the African continent, for example, in Sweden. And it really is just a matter of time before we see this clade of the Mpox virus here in the United States. Just this week, the United States, the Department of Health and Human Services announced that they're donating 1 million doses of the Jynneos vaccine to help stem this international Mpox response, because countries like the Democratic Republic of Congo and neighboring countries have just not had sufficient number of vaccine doses to immunize and protect their populations.
Does the vaccine prevent against both clades?
Yes, the vaccine will prevent against both clades of the Mpox virus. So we don't really have to worry about that. It's just that the epidemiology of the two clades is different. The risk factors for infection are different with the two clades right now.
And there seems to be, in what you've seen from, you work with IVAC, and there seems to be a limitation here, not just in the supply of vaccines of Mpox, but in the actual distribution of them. Could you just talk a little bit about that?
Yes, and this is not an uncommon problem. And this played out, it's really, I'll say what's upsetting is that this is exactly what we saw with COVID-19 vaccines, where the wealthier countries that could afford to set up bilateral arrangements with the vaccine manufacturers actually often had more vaccine stock than they could actually use. Whereas countries, and it's going to be the lower income countries, particularly countries in sub-Saharan Africa, but also in Asia perhaps, where they do not have access to the vaccines. And so what we saw play out during the COVID pandemic and the inequity in COVID-19 vaccine access, we're actually seeing again with Mpox. And so this is a serious, important problem that we need to address. The COVID-19 pandemic drove efforts to have vaccine manufacturing capacity on the African continent, to build that capacity so they can manufacture and distribute vaccines within the continent so we don't get this gross inequities in vaccine access.
And it seems even more complicated because this is not just a one and done vaccine, right? It's a series. So you've got to vaccinate people once and then have them come back. And this is in an area that is complicated to reach and all of those things.
Yeah, you're exactly right. The Jynneos vaccine is a 2-dose vaccine schedule. There's ongoing discussion right now about whether there need to be booster doses for this vaccine. Some recent studies suggesting some waning immunity there. So we may be talking about booster doses for Mpox vaccines as well. But you're exactly right. When you're working, and again, this isn't unique to Mpox, but probably made even more difficult because of the target population. We've gotten pretty good at getting vaccines to young children. Still a lot more work to do there. On the order of 20 to 25 million children miss out on their routine childhood vaccines each year. But getting several doses, 2 doses or more into adults, that's challenging. And again, we saw that during the COVID-19 pandemic with COVID vaccines.
Last question for you. Let's talk about some new vaccines. What's in the pipeline for these infectious diseases?
Yeah, so some of the ones that I'm excited about, I'll say first, malaria vaccines. We now have 2 WHO pre-qualified vaccines for malaria. Malaria kills close to 500,000 children each year. And so we've got these two vaccines, the RTSS and the R21 Matrix M vaccines, that are being rolled out in high burden settings in sub-Saharan Africa. These target the malaria parasite Plasmodium falciparum. So I'm very excited to see, continued rollout of these vaccines, but there are enormous challenges in getting these vaccines to children. These require multiple doses at an age range that's outside of the traditional routine immunization program. So there are definitely operational challenges there. In the pipeline are vaccines for tuberculosis, which of any single pathogen kills more people than any other pathogen. And so I think we're on the brink of seeing effective vaccines against tuberculosis that will be have tremendous global public health impact. And then lastly, there are a number in the pipeline, but I'll mention RSV vaccines, respiratory syncytial virus vaccines, just coming out over the past year or two. An interesting vaccination strategy, giving the vaccine to pregnant people so that their infants are protected in the first few months of life because of this passive transfer of protective antibodies from the mother to the infant in utero in the last trimester of pregnancy.
Well, Bill Moss, thank you. This has been a very far-reaching conversation on vaccine-preventable diseases. We appreciate you coming back on the podcast.
Thank you. Thank you very much, Lindsay. My pleasure.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith Rogers, Stephanie Desmond, and Grace Fernandez-Ciceri. Audio production by J.B. Arbogast, Holly Cardinale, Spencer Greer, Matthew Martin, and Philip Porter, with support from Chip Hickey. Distribution by Nick Moran. Production management by Catherine Ricardo. Social media run by Grace Fernandez-Ciceri. Analytics by Eliza Rosen. If you have questions or ideas for us, please send us an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.